Thank you so much for the invitation to give the Charles Franklin Craig Lecture at the ASTMH meeting 2022. Dr. Craig was a bacteriologist and a pathologist who dedicated his life to studying infectious and tropical diseases, especially malaria, and he discovered and described the Plasmodium ovale. So it is a real honor for me to give this lecture. It was difficult to decide what to talk about. I thought about sharing with you my own journey as a low-middle-income country woman researcher working in global health. Or maybe I thought about talking on Carrion's disease or human Bartonellosis, which is more than a neglected disease. And it's found mainly in the Andean valleys of Ecuador, Colombia, and Peru, my home country. Although it is an ancient disease, there is a worrisome lack of knowledge about the vectors, possible reservoirs, the dynamics of transmission, and adequate treatment. But there is also clear evidence that the illness is arriving to new areas due to the expansion of the vector's distribution, thanks to climate change. But finally, I decided to talk about COVID in Peru, since many colleagues have been asking what happened here. I really regret not being able to give this talk in person. I would have loved to answer questions and have a more interactive lecture, but you could always email me. The problem was that while being on another meeting just before going to Seattle, I got COVID, and I have been sick for a while. So let's start. Share the screen, and here we are. So let's talk about the lessons from COVID in Peru. And the pandemic has been devastating for the world and for some regions more than others, and Latin America has been hit very hard. On February the 26th, Brazil reported the first case of COVID before WHO declared the pandemic. And 8 days later, every country in Latin America had reported COVID cases. The epidemic initially affected higher income groups returning from abroad and their close contacts, but it spread rapidly to lower income populations that have less access to health services. There are several contextual similarities within the LATAM countries: economical, political, social, and cultural. We all have indigenous communities too, but probably one that has been critical is that the whole region, our countries and the whole region, we all share the most inequitable region in the world. So what about Peru? Peru is a very diverse country located in the center of Latin America with 33 million inhabitants and 1/3 of the population living in the capital city, Lima, which is a megacity. We have been having a fast-growing economy, but it is based mainly on a labor force that is informal or unregulated. And about 40% of the people are self-employed. This rate is the highest rate in the region. We have a very weak social protection system with poor housing and overcrowding. And in these past years, we have been living this political crisis and instability. And during the pandemic, it included the change of several ministers, the Congress, and presidents. So, additionally to that, we have a fragmented health system that is under-budgeted, but serves about 92% of the population. We have poor quality public services and a weak primary health care. Additionally, we have a limited capacity for molecular testing nationally at the beginning of the pandemic. So, knowing all these things, Peru began its pandemic response preparations early. And in February, early February, the government released the COVID-19 National Plan for Preparation and Response. However, there were delays and difficulties purchasing PPEs and any types of supplies. By March 6, we have the first confirmed case, and by March 15, the president declared a state of national emergency and lockdowns with very strict controls of citizen movements, except to purchase food or pick up medicines, and it was a mandatory use of masks. Remote work was introduced, and only people that work in critical sectors were allowed to commute. The national borders were closed, and schools and universities were closed too. One thing that was very peculiar was that due to the lack of molecular test supplies and the lack of laboratory capacities, the government decided to purchase serologic tests. There were 1.5 million tests, rapid tests, that were purchased in April 2020. The National Institute of Health validated them and created an algorithm for its use, and it was implemented for the detection of cases. So we had a very particular definition of confirmed infections. In Peru, from almost very beginning, a confirmed case of COVID was any individual with or without symptoms that had either a PCR or a serologic test positive. And eventually, when the antigen test started to be available, also we had confirmed case with antigenic tests. So we went through the first wave of COVID, which evolved between March to November 2020, and we have more than 800,000 infected individuals. The first wave resulted in more than 30,000 deaths, and by the end of the first wave, according to serologic studies, 40% of the population in Lima had detectable antibodies against SARS-CoV-2, and in the Jungle region, in Iquitos, more than 80% were serologic positive. However, the second wave started in December 2020, after the political protests, economic openings, preparation for holidays, festivities, and when the summer started. And this second wave lasted until July 2021. Compared with other parts of the world, the second wave in Peru was driven mainly by the Lambda variant. The Delta variant was seen only at the end of the wave. And early in 2022, we had the third wave driven by Omicron. So you could see that the number of cases was several times higher than in the previous two waves. And we have had also a fourth wave, and now we have started a fifth wave of COVID. Peru has had the highest COVID death rate as the proportion of population in the world, according to the latest data. The first and the second waves were the deadliest ones. And although vaccines arrived in Peru for the very first time in February 2021, the numbers of vaccines available were very limited, and it was only until June that vaccinations started to catch up. So many deaths could have been prevented with earlier vaccine access. The acceptability of vaccination has been very high in the country, as it is in other Latin American countries. So we had also a third wave and very low mortality with the fourth wave, and so far it's still very low with the fifth wave. But the pandemic has impacted the country in so many other ways. Poverty rates have increased, as well as the informality, and education has been affected due to complete closure of schools and universities. And the question that everybody asks is why Peru has been affected so badly when Peru imposed one of the earliest and strictest lockdowns in the world. So to answer this question, I would like to use the framework for COVID-19 responses strategies adapted from Han to analyze the pandemic response in Peru and extract some lessons. We will use each of these four groups to understand what happened with knowledge of infectious status, the community engagement, health system capacity, and the public health capacity. Regarding the knowledge of infectious status, Peru had open data, which was promoted by the MOH group of experts who were academicians. We used the electronic surveillance system developed for other transmissible diseases called the NOTI-Web, to be able to gather and process national data. Regarding the deaths, it was very unique in Peru that we used electronic system for death certificates that was called SINADEF. SINADEF was started in the country in 2017 when I was Minister of Health, and it was progressively implemented. So early in 2020, the decision was to use it for the pandemic and to train providers and involve the regions also in the use of this tool. The data from death certificates was available at almost real time, and there was an incentive that the government provided, which was cash transfer for funeral for families that reported the cases. So we were able to get information about probable and confirmed cases, either with PCR or serology or eventually with antigenic tests, and also to record information if the patient was dying from at the health establishment or at home. The data was reviewed and discussed by members of the Ministry of Health group of experts to recommend refining policies and strategies. So the Economist published interesting data comparing the estimated excess deaths around the world versus official reports. And as you can see, Peru is one of the countries with the best official reporting. So we can say that we did very well regarding the knowledge of infectious status and mortality. Open data and an electronic death certificate systems were key. So what about the next area, the area of community engagement? So for community engagement, there was no convener of civil society, private sector, people, or communities, and there were limited efforts to address people in the informal economy, where people had to choose between quarantines and staying home or going out to the streets to work in order to have enough money to survive. Communication to secure public trust was very limited, and we failed protecting vulnerable populations. We have weak social protection policies, and there were no registries of vulnerable population. And although there were some provision of social economic support, it was still disorganized and had low coverage. Policies and support for indigenous populations were also delayed and insufficient. So we failed in engaging communities and reach those in need. Regarding health system capacities, as I mentioned before, we knew that we had a weak and fragmented system. Unfortunately, there was this decision of having a hospital-centered pandemic response, and the primary care centers were closed during the pandemic. Peru lacked ICU beds, ventilators, and health providers because there was a high percentage of health providers that were in the age of vulnerability or were vulnerable because of diseases. So we also lack EPPs and oxygen. And although a huge effort was made during the first wave, we were able to increase the capacity of ICU beds and ventilators from 900 nationally to more than 1,500 beds in the ICU and ventilators. And in the second wave, we were able to get close to 2,800 ICU beds and ventilators. But still, it was not enough, and we failed terribly in this area. Regarding the public health capacity, there are two areas that we would like to discuss. So one has to do with testing, tracing, and isolation. And we'd like to talk a little bit about also the rapid test. So the Ministry of Health started a hotline that was the 113 and a website for symptomatics. However, people was calling, but there was no way to visit them or testing them. There were no PPEs and there were no tests. Eventually, testing teams were trained and equipped to go to the homes of the people that was calling to do the rapid test using the algorithm provided by the National Institute of Health. Those that were IgM or IgG positive with mild symptoms were asked to stay home, whereas people who needed critical care were referred to the hospital. The contact tracing was really very weak, and the isolation of cases was not very effective. Quarantines were mainly at home, and there were very few quarantine facilities. At the beginning, everybody was against the rapid test, but then there were lots of tests that came out to the market, even without any quality, and anybody could do rapid tests, and it was started to be sold in the black market, and people started using it as a way of showing that they were not sick or when they wanted to expose themselves. So the other area of public health capacity was the role of experts. And for me, this pandemic has brought the most frustrating experience in my professional career related to the role of the experts. I have tragically realized that the evidence to policy ecosystem is broken. So let me explain myself. Very early in the pandemic, the Ministry of Health created several committees of experts, including academicians, practitioners, and researchers from the main universities in the country with the objective of advising the government. For example, one of those commissions or committees was the one I chaired, and it was called Innovations for COVID, in which we aim to advise on evidence-based health technologies, including interventions. We identified some cross-cutting issues like regulatory pathways, which hindered the validation and introduction of health technologies, the need to promote open data, funding issues in order to work with these new technologies, the need to create communication channels with the public, policymakers, media, highlighting the new technologies that work and those that do not. The committee met several times a week, prepared reports and recommendations, but it became very frustrating because only few of the things recommended were taken into consideration by the Ministry of Health. And instead, important national recommendations were not evidence-based. One of the most frustrating examples was the approval of the COVID treatment packages and the release of the national guidelines for treatment for COVID, recommending Ivermectin for mild and severe cases. And that happened in May 2020. This happened against the recommendations of our Innovations Committee and against the recommendations of half of the members of the Treatments Expert Committee. The Ministry of Health from Peru and also the ministers of health of other Latin American countries, Bolivia, Paraguay, Brazil, made the decision under the pressure of practitioners facing with patients in serious conditions that were asking what can be done. So there was a lot of vehemence there. Also under the pressure of some eminent physicians referring unverified anecdotes of miraculous recoveries among patients taking ivermectin. And also, they made the decision under the pressure of people's desperation and political pressure of showing something. So, at the end, we have the recommendations that were not based in evidence and were based on vehemence or eminence. And unfortunately, they were backed up by the now withdrawn preprint from MERA based on the database of the scandal-hit US company Surgisphere Corporation. That is the one that you see at the bottom. And a paper about the in vitro activity of ivermectin, which unfortunately had a very misleading title because it talked about the FDA-approved drug ivermectin, and most people that read it thought that it was already approved. The paper showed inhibition in vitro, but the concentration of the drug that was used also was equivalent to 50 times the tolerated dose of ivermectin. This last paper's publication was prompted a response from the US FDA, which issued a warning, but the damage was already done. Even without scientific support to guarantee its efficacy for COVID-19, ivermectin was everywhere in Latin America. And this happened almost 1 year before the fever of ivermectin started in Europe and the US. Ivermectin is an inexpensive over-the-counter medication that is very popular among people in Latin America to treat parasites. And once it was authorized for COVID, it started to be recommended and even massively purchased. Politicians voiced that the country didn't have time to wait for scientific evidence. And the president's announcement that the government had acquired nearly 500,000 doses of ivermectin for use in coronavirus prompted people to run to the pharmacies to look for the drug. And soon, all the supplies ran out, and people turned to the black market and veterinary versions of the drug. It was really a nightmare. Religious and political groups started to distribute the veterinarian form of the ivermectin, and even making people to think that it was a vaccine. We have reports of people with blisters and ulcers, like the one you can see there in the slide, where they have been injected with formulations intended for animal use. We also have side effects, including stomach problems, tremors, panic attacks, and severe neurological toxicity, especially in children after taking too much of the drug. And the infections and the deaths due to COVID continue on the rise. There were multiple side effects related with this policy. This policy that was based on vehemence and eminence instead of evidence-based. The uncontrolled and unsupervised uses, and the self-medication, and the use of veterinary formulations all led to severe toxic effects. This standard of care, in quotations, really prevent and hinder the implementation of clinical trials to evaluate if indeed there was some effect. We tried and we started a clinical trial, but it was really a challenge to recruit people to participate because the drug's popularity make this recruitment difficult because most of the people had been already taking ivermectin. So probably the most devastating side effect has been the false hopes and the false sense of security that ivermectin gave people. People start taking ivermectin not only for treatment, but also as a prevention. They were taking it daily, several times a day, or even as the after-day pill for COVID, feeling safe from breaking the rules. I think this has been another important reason for the failure of the control of the pandemic in Peru and for the terrible outcomes we have seen. In October 2020, all the members of our commission resigned, and in November, after all the pressure from academics, ivermectin was eliminated from the guidelines from hospitalized patients, and only in February 2021 for outpatients too. By that time, we were already on the second wave. But unfortunately, I have to tell you that I have seen that physicians are still prescribing ivermectin to people with COVID in this fifth wave. So we have failed in this area too. What I have presented is really something that I call the evidence to policy ecosystem that is broken. The public at the very beginning of this epidemic wanted to believe that science, through evidence, was going to guide everybody to the right path to prevention and cure. Scientists failed by releasing fake data and failed to communicate important findings well. Journals looking for speed failed to screen well what was shared to the public in pre-publications. Practitioners that are used to overtreat and that had limited knowledge on what evidence-based is promoted and used unproven drugs like the ivermectin. And the public with very low levels of health literacy self-medicated and even used veterinary formulations. And finally, the politicians used this opportunity in a very populistic way to promote their image of efficiency. So in every single point of this cycle, we see that it is broken. So we can get from these 10 important lessons that I would like to bring. So number one, contextual evidence is needed to understand the responses during the pandemic. The ecosystem from evidence to policy is broken and has failed completely during the pandemic, and we need to acknowledge that, and we need to do something. Scientists and health professionals need to assure quality evidence is well communicated. The desperation of the public and the providers really led them to lose objectivity. So we need to think that ahead and prepare ourselves before the next pandemic. With so much information, it is difficult to make sense of what is real evidence and what is fake. The efficiency in the training of health professionals in evidence-based medicine is something that we need to bring over the table because we need to do something. And the other thing is that what we have seen is that over-treatment practices are generalized, and those need to be also approached and changed. Poor health literacy and frequent self-medication is still a common behavior. It has been very hard to produce new evidence because there has been no funding support, especially for low-middle-income countries. And the regulatory frameworks for public health studies during emergencies have been very complicated. And finally, interests, politics, and populism have also pushed false evidence or no evidence into policy without any accountability. So, at this point, the question of why Peru's coronavirus response was right on time and why we were hit so hard, I have gone through the different factors, contextual factors, limited laboratory capacity, probably this massive purchase and use of serologic rapid tests and overuse, because people were using it also as health certificates. The fact that we have a weak health system and decided for, wrongly, I think, for having a hospital-centered pandemic. But probably one of the most important things, and one thing that has been critical, has been this use of medications without evidence that had caused adverse events, toxicity, and complications, and antibiotic resistant, and this false sense of security in the population that have been exposing themselves more frequently. So, as conclusions, yes, Peru started early with restrictions, but has been hit hard by the pandemic. We had a very good information system, so it's good to have good data, but it's not enough if decisions are not made based on evidence. And I think for me, we have to work on the context. We need to work on improving our health system, of course. We need to have better policies for social protection. But one thing that we have to work on, and I have not seen discussing enough, is that with the evidence that we have that the policy ecosystem is broken, as a global community, we need to acknowledge it and start working with the different stakeholders to fix it. So thank you very much for this opportunity. And you have here my email for any questions or discussion that you would like or to start. Thank you so much. Bye-bye.